Where is Falak? Is Falak still here? Okay, so Falak is not here. She requested a station. She is not here. Let's see. Does somebody want to do a question, a station? Okay, we can start.
So this is for me?
Yeah.
Oh, okay.
Yeah.
Okay. Hello, I'm Usha, one of the doctor in antenatal clinic today. May I just confirm your name and age, please?
Hi, doctor. I'm Sylvia and I'm 27.
How may I address you?
Sylvia is fine, doctor.
Okay, Sylvia, you can call me Usha. So nice to meet you and welcome to coming clinic.
Thank you.
I am aware of that you are 10 weeks pregnant. And
yes.
Yeah.
Is it 10 weeks?
10 weeks.
Okay.
Yeah.
Thank you. Yeah.
And you had one episode of epileptic fit 2 weeks ago. Is that right?
Yes, doctor, that's right. Yeah.
Okay. And also, I'm aware of that you want to home birth.
Yes, doctor. Yeah, I really wish I could have home birth.
Okay. So is it okay if I ask you a few questions to know more about fits, epilepsy, and also pregnancy? Then we can discuss your birth plan. Would it be okay for you?
Okay, yeah, sure.
Okay, thank you. So could you tell me a bit more about your epilepsy?
Well, doctor, my epilepsy is, it's okay now. Like it was very bad before. So then they changed my medication. And now this medication, I've got a bit less fits. Like I had a fit 2 weeks ago, but still it's better than before.
So you had a 2 week before, so but it is not completely controlled.
It's not completely controlled. Yeah, I agree with you. Yes.
And I'm aware of you did not take folic acid in this pregnancy.
No, doctor, I just suddenly found out, that I was pregnant. So I didn't know that I had to take any medication.
Okay. So is this your unplanned pregnancy? I believe, yes.
Yes, yeah.
Are you happy to continue this?
Yes, indeed, I am. Yes.
Okay. And were you using any sort of contraception?
I was on some pills, but I think that I think they didn't work. Yeah.
That didn't work. Yeah. The reason because you are taking this medication, so that that medicine interfere with pills, so it's not as effective as it should be. Yeah.
Okay.
Okay. And when was your last visit to your doctor? Are you following your epilepsy doctor?
It's been a bit long time now. I saw him, I think 6 months back.
6 months back. Okay. So it seems like your epilepsy is not well controlled. So what we need to hear, apart from that epilepsy, do you have any other medical problem which
No.
you follow? Okay. And no other medication are you taking apart from this carbamazepine?
No, I'm not taking any.
Okay. Are you allergic to anything?
No, I'm not.
And any family history, anyone else in having this condition, epilepsy?
My sister has epilepsy.
Okay. And what about your partner? Is he fit and well?
Partner is fine. He's fit and well.
Okay. And sorry to ask, is that your first pregnancy or have you been pregnant before?
This is going to be my first pregnancy.
First pregnancy. Okay. Do you smoke?
I don't.
Okay. Alcohol?
No, I don't like alcohol.
And any other kind of recreational drug?
Never, no.
Okay. May I know your height and weight ratio? We call it BMI.
I think it's 23. The GP did it recently, so that's why I know. Yeah.
Okay. And any reservation for blood transfusion if it requires in?
No, doctor, no worry.
Oh,
No.
okay, no problem.
Do I need?
Okay. No, we are not sure. So that what we will arrange a ultrasound for you today, and also the blood test to see other kind of we do for every woman, like blood sugar level, HIV, and rubella and hepatitis. We do for every woman, and scan because you are 10-week pregnant. We will confirm with ultrasound to
Okay.
make sure baby is inside you, inside womb, because
Okay.
it's early. And
Okay.
also further care will be under a consultant led unit,
Okay.
as this is a high risk pregnancy, and I will involve your doctor,
Okay.
because the one thing I am worried, as you haven't taken folic acid and your epilepsy is not well controlled with one
Yes.
medication, so your doctor might need add another
Okay.
medicine to
Yes.
control the blood epilepsy.
Okay.
And two medicine, they are, I'm sorry, the two medicine, they are risk for baby
Okay.
more. Yeah.
Which
So
medicine, doctor?
like we don't know which medication your doctor will add on this carbamazepine, because your epilepsy is not well controlled with one medicine. So
Okay.
your doctor may add another one.
Okay.
So and two medicine are on high risk of baby to
Oh.
have a an abnormality in baby's back of vein. We
Oh.
call
So
it congenital anomaly.
so why would you give me then? So what would you do then?
Um, we actually we will check your ultrasound first inside, and then we involve your doctor to we will give you 5 milligram folic acid now. We will prescribe, but it's already 10 week, because if it is any abnormality happen in your baby,
Okay.
because the development of backbone is already happen. So, and we will arrange mid pregnancy scan 20 week, then we will find out the baby is having any abnormality or not.
Okay.
Yeah.
Okay.
So and you will be, as I said, your pregnancy care will be under my consultant and your doctor and specialist midwife, and you will have extra scan, and extra care need to come extra for extra visit to hospital.
Okay.
And if your baby is fine at 20 week on his scan, and then your pregnancy will be, as any other way, lady.
So
Am
then
I
I can
clear to?
deliver at home then, you mean?
No, I'm coming to that point, and delivery at home is very risky, because during delivery, we recommend delivery at hospital where all the facilities available. During labor and after just delivery, fits are very common. Am I
Oh.
clear to you? So yeah, and because uh,
They really wanted to deliver at home.
yeah, I really respect your wishes, but I am here to give you inform all. You should know all the complication so that you can make your informed decision. Am I clear to you?
Okay,
Yeah,
doctor.
there are because during, as I said, during labor fits can more likely chances happen, and after delivery adverts. So we and in these kind of situation we put IV line, means a plastic cannula, and sometimes we need to control if fits happen, control the giving medicine by IV line to control instantly. And also and baby will be checked after delivery. There is a risk of uh, mm, after and a delivery fits, so we need to give medicine instantly.
Okay. So anything else then? Would you?
Yeah, as I said, first thing actually, because there is a so I'm giving you information leaflet and whatever we discuss, and right now I'm giving you high dose of folic acid, and inform my consultant about you, and whatever we discuss we will document it in your file. And further, yeah, thank you for your time. Anything else do you want to ask?
No, time is up. So your screen is gone. So there's no
Oh
time.
my goodness.
What do you think you have covered, and what do you think you haven't covered?
I could not cover because this she already fits. So this patient need to another medicine, and to control, because fits will be, actually epilepsy I did not read very long time.
Okay, okay,
But,
okay,
so,
okay.
as I remember, she needs more, another medicine.
Somebody else wants to give it a try as well, or shall we just continue with? Yeah, somebody thinks they can present.
Yeah, I forget to during labor pethidine should be avoided. That's
Okay,
the patient safety. And
okay. Anything else?
and there are so many things, because if everything after delivery she need to feed her baby on the floor, so many things.
So
But
I know what you missed, Usha. That's fine. Now I'm asking, does any other warrior want to jump in and do the same station again? Yeah,
Yep,
and then we can talk.
I want to do it once. This is Shilpa.
Okay, Shilpa. Yeah, all right. So let's start with the same question. Let me try to sit down a bit. Ouch. So I like to stand when I'm doing this, but then
all this time you are standing.
Yeah, yeah. I like to stand. So now I'm sitting. I was a bit tired. Okay. So yeah, let's give Shilpa another go of this one. Yeah. And don't mind if I offer yet another person as well, because I like you to keep listening to it and keep thinking what went better, what went better, and the same station, because in the same station, that keeps evolving. One person does a mistake, then the other person doesn't do that mistake, then a third person. So it keeps evolving, and then you keep focusing that, okay, why has the other one gone better, and what could have been done. So let's go back to where is my.
So I will also do then.
Yeah, sure. Most welcome. I saw your mic moving before Shilpa, and I'm happy with both of you. So you don't need 2 minutes for this question now. Yeah,
I think I need 2 minutes. Let me formulate.
Organize yourself. Yeah, absolutely. You should. If you need, then you should. Let's see. Share screen. This and this. Okay, share. And now I'll start. Okay. Let's see. Okay, let me stop this for a second. Can I verbally inform you that please assume that you have a scan showing that this is an intrauterine pregnancy. Okay, you have a scan from GP showing that this is an early scan showing that this is an intrauterine pregnancy. Okay. Okay.
Okay. Hello, I'm Dr. Shilpa in the clinic today. May I confirm your name and age, please?
Hi, doctor. I'm Sylvia Howard and I'm 27.
Hello, Sylvia. How are you doing?
I'm good, doctor. Thank you for asking. How are you?
Very well, thank you. So, Sylvia, we have received a letter from your GP mentioning about your concern. I'll be happy to know if you can mention the same in your words. So we are meeting because you are pregnant, correct?
That's right. Yes, doctor.
And you had medical issues.
Yes, doctor. Yes, I have epilepsy for a
Yes.
long time. Yes, yeah.
And you are taking medication for that? The
Yes, I
carbamazepine?
was on some other medication. Then about a year and a half ago, the doctor changed it because my fits were not in control. I was having like every other day. And with this medication, I'm not fit free, but it's like every 2 to 3 weeks I can get a fit.
Okay. Have you ever been admitted in hospital for epilepsy being not under control? Like they have to admit you.
That was when I was on my previous medicine. That happened. Yes.
Yeah. And you feel these medications are working a little better than the old
A
one?
little better. Yes, doctor.
When was the last time you happened to visit your general practitioner?
GP, I saw him when my pregnancy test was positive. He arranged this ultrasound scan, which I have.
Yes. And prior to this, the doctor for the epilepsy?
That was about 6 months ago.
Okay. And yeah, and in this 6 months, you had the fit, which was 2 weeks ago. Is that correct?
And not only that, I had previously as well. So as I said, it can happen once or twice in a month.
Okay. Okay. So how has been pregnancy so far?
I just found I felt some sickness in the morning, and I was like, I was not expecting, but then I thought my periods were just being a bit irregular. So when I did the pregnancy test, I was like so excited. It was like sudden,
Okay.
but
I'm happy to hear that. Okay. So you'll be happy to continue the pregnancy. Is that correct?
yes, indeed, I will.
Okay. Okay. So any supplements, any multivitamins, anything you were taking other than the carbamazepine medication in general?
Doctor, I sometimes try to take some multivitamins, just for not because of course I was not aware of pregnancy, so I
Yes.
do sometimes take, but but a bit irregular, of course. I didn't know.
Okay, so Sylvia, about your epilepsy and the previous medication, can I look over to your notes with your permission? What exactly was the affairs earlier? Is that
Yeah,
okay
sure,
with you?
no, sure, doctor.
Okay, you Sylvia, have you been ever operated for the tummy or any surgery down below?
No, I have never been.
Are there any medical issues other than epilepsy that you happen to see your GP for?
No, not at all.
Okay, what contraceptive you have been following and this pregnancy happens?
I was on Yasmin.
Okay, and you were regular with it. You're regular with the medication as well. Are you a
Sometimes
person
I
who
could
is-
forget. Yeah, sometimes I can forget.
Yeah, about you can forget carbamazepine and sometimes Yasmin too.
I normally I don't forget carbamazepine, but I forget my pill sometimes. Yeah.
Yes, Sylvia, you know, right? Yasmin is a very low dose pill. It's highly effective, but the compliance with the medication is really required to not to have accidental pregnancies, right? Okay, so whenever we're, I think we'll talk about this later as we proceed. Okay. Yeah, all right. Okay. Do you want to mention about the allergies? You have anything for me to just note down any?
I don't.
Or any? Okay. Do you take alcohol, Sylvia?
I don't like alcohol, so no.
Okay. And smoking?
I don't smoke.
Or any drugs for recreation?
Never.
Okay. Do you know your BMI?
It's 23, and the GP did the other day when I went there.
Okay. And are you aware of your blood group by any chance?
No, I'm not.
Okay, Sylvia, thank you so much for sharing this information. You had a family history for any epilepsy or any diseases of concern that you want me to be aware of?
No.
No? Okay, okay. Thank you so much for sharing this information. And I have received your sonography, and I've confirmed that sonography belongs to you. We have a baby who's looking just perfect on the scan, and your
Okay,
blood work
thank
is
you.
all good. Many congratulations to you.
Thank you, doctor.
Okay, so yes, about the epilepsy, can I move forward and discuss a little bit about epilepsy, how it can affect you and the
Yes,
baby in
please.
pregnancy?
Yes, please. It was really
Okay,
nice.
so Sylvia, most of the people who have epilepsy do very well. They deliver nicely. The babies are also very well.
Okay.
But there's certain risks that we have to be aware when the lady gets pregnant with an epilepsy.
Sure.
Okay, and for the baby as well. So what are the risks? Like every person can have some anomaly, some different type of a problem with the baby. And we call that risk as a background risk, you know, that
Okay.
anybody can have a problem. And when there is a person who has an epilepsy and has been on the medication, that risk little bit increases. So
Okay.
is generally 2% for everybody, like 2 in 100 can have a problematic baby, or the different type of a baby, if I'm saying.
Okay.
People with epilepsy and who has been on carbamazepine, I must assure you the doctor has put you in a wonderful medication. It is going to give you less of the side effects to the baby. Only thing, I am going to re-refer you to your doctor so that we can increase the dose so as to give a better control on the medication. Okay.
Yes, thank
And
you.
and in for this is one of the risk that yes, most of the women, like 1/3 of the ladies, can have epilepsy going little haywire. Our epilepsy is also not very much under control, you know, Sylvia. So we have to be little particular upon making sure that you should be fine and taking the medication. No missing pills of carbamazepine, right? No pills that you should.
No. I'll put an alarm.
Okay.
Yeah.
Yes, okay. And I'm going to put you on folic acid. So usually we give folic acid, the best time has to be like 3 months prior to getting pregnant and during the pregnancy and first 3 months. So it's never too late to be on a pill, is far better than not having it now.
Okay.
Though how much it is going to be effective is like a controversial thing, but it's better to be on the medication now.
Okay.
Okay. So second part is that I'm going to book you on with our consultant. You people with epilepsy, we would consider as a high risk pregnancy. It is better to be under a consultant. Okay. And usually we have the multidisciplinary approach in which they're going to be a neurologist, your general practitioner, trained midwives who are going to handle your pregnancy. Okay. Okay, we are also, I would be happy to talk to your partner, because whenever, what are the cares that we have to make sure when you're pregnant, and if you have the episodes, we need the partner with you to be trained to handle in case there's an emergency. Okay. Second, yeah. So about the antenatal visits, they're going to be a little more frequent than the usual person. We're going to see you a little more often. And around 36 weeks, we are going to, what we usually do is we plan for labor. There is no reason for you to have a cesarean section in the epilepsy. You are just like any other person. Of course, your monitoring has to be more correct. There are certain, we offer pain relief in various modes like injectable, inhalation. But in your scenario, pethidine will be one of the medication which we usually use commonly, would not be advisable for you, correct? Other option like taking an epidural anesthesia or other modes would be discussed with you in detail. Okay. And about your concerns, what do you think? Where do you think you should deliver?
I requested that I wanted to deliver at home.
Yes, I saw that request. Yes. So Sylvia, now birth home is an excellent idea. You are away from all the hush push of the hospital, nobody to interfere. But truly speaking, my dear, this is not a very good idea for us. You know, when we have epilepsy, it is better to have all the people around. We make sure we are going to give you a separate room so that we do have less of the disturbance from the hospital. But you require to be under a consultant, and that's for your safety, Sylvia. It is, well, I'm here to give you options. I hope you, and of course, we're going to discuss the risk pertaining to those times, right? If you have an episode which is there when you are in labor, so we have a group. I'm done. Okay, I'm sorry, I'm finished.
That was marvelous, excellent. But we'll talk about few things that you could, you could change. It's not about improving. There are few things that need to go. Other than that, I'm impressed. Okay, so don't go away. We'll come back to your feedback in a minute. Okay, Sunanda, do you want a little bit of her and Usha's feedback first, and then you want to jump in by improving on those points, or do you want to just first give it a try?
I will try. Because I may get again some points.
Yeah, you
to add
don't
on.
want to be getting the. You don't want the advantage of. Yeah, I understand absolutely. So, do you want 2 minutes?
No, I don't want.
You don't want 2 minutes. Okay, all right. He's ready. Okay, wait. Let me stop the share and let me share the. Oh, why did I stop the share? When you said I'm ready, I forgot that you still need to see the timer. I mean, for the.
I want the 10 minutes timer.
Yeah, absolutely.
Sylvia, 28, right? Or 27? Sylvia, 27?
27, yeah.
Yes.
In front of you in a minute. Let me put the timer here. Okay.
Yeah.
Mm-hmm.
Hello, I'm Dr. Sunanda, one of the doctor in the antenatal clinic today. May I cross-check your name and age, please?
Hi, doctor. I'm Sylvia Howard and I'm 27.
How would you like me to address you?
Sylvia is fine, doctor.
Okay, Sylvia, I could see that you are into 10 weeks pregnancy and you do have a condition called epilepsy and you are on medication and you are here to see, you have come for the birth plan. Is that right?
It's right. Yes, doctor.
Do you have any other concerns and expectations from this consultation?
No, I just want to know how it goes and all that and what should I be doing? Okay.
Okay, Sylvia, I'll be addressing in a moment. If you don't mind, I'd like to ask a couple of questions to know more about you as well as your condition, that is epilepsy. Will that be okay with you?
Okay, yeah, sure.
So can you tell me about our pregnancy, how things are going on till now?
I suddenly found out I'm pregnant, so nothing, it means that nothing too terrible happened. I was just feeling a bit nausea. So I thought that first I thought I ate something, but then I did my test and it was positive, and my GP did the scan. So that's,
okay.
Yeah, he sent
okay, fine. And is it your first pregnancy?
It is, yes, yeah.
Is it a planned one?
No, doctor, as I said, I wasn't sure that I was pregnant at all. No.
Okay. Do you have any nausea, vomiting right now?
Just a bit of sickness. So the doctor gave me some tablet for that. And it was
okay. And can you tell me about your epilepsy a bit more?
Yeah, epilepsy is better now. Like about 18 months ago, I was on some other medication and I was having fits every other day almost, and it was very, very bad. I needed to go to the hospital as well, got admitted, and now it's like I get sometimes once in a month, very unusually twice in a month I can have a fit.
Okay. And when did you visit your last visit to the doctor, epilepsy doctor?
That was 6 months ago.
Okay. Did you discuss about your pregnancy care plan anytime while you visited
No, I
him?
never thought about pregnancy.
Okay.
Yeah.
Okay, fine. So, Sylvia, do you have any other medical conditions apart from this?
No.
And how is your periods? Are they regular?
Yes, yeah.
And did you get...
They were slightly like, sometimes they could be here and there, and normally I actually never bothered to note how regular they are. I think they are every month. Yeah.
Okay, yeah. So are you, did you get a cervical screening invitation?
I had a screening, yeah.
Okay.
Was
and
not.
Any surgeries on your tummy or down below?
No.
And are you allergic to any substance or medications?
No.
And I could see that you have not started with folic acid. Is that right?
Yes, doctor, because yesterday only I found out. Now my GP did prescribe me now, so I've started, but only since yesterday.
Okay. Can I know what is the dose?
He said I needed a high dose, so I.
Okay. Yes. So, Sylvia, is there any other things you would like to add on?
No, I just wanted to know if I can give birth at home, and if there's anything special that I need to do for this pregnancy because of my epilepsy. Or
definitely. Then I would like to tell you that the scan report has confirmed your name and NHS number, and it shows that baby is doing quite fine. And Sylvia, I would like to discuss regarding the effect of epilepsy on your health as well as for the upcoming baby. Okay?
Yeah, sure, doctor.
Yeah. So as you know that epilepsy being a condition which is a high risk, and henceforth your all visits will be in the consultant-led care unit with a multidisciplinary team of health professionals involved in your care, so that we can reduce and minimize the risk involved in your health and your baby's health. Like my senior consultant, me, and your epilepsy doctor, as well as general practitioner will be involved in your care, along with the special midwife. Okay, Sylvia?
Okay.
And let me explain to you, for your health, we are a little worried because women, when they have epilepsy and it's not controlled, as I can see that you had fits 2 weeks ago, so you may get again fits in your pregnancy. We are really worried. So we would like to see you frequently. If you get again fits, you may need admission for to handle further.
Oh,
Okay.
okay, doctor.
And as pregnancies are high risk and it causes a stress on your health, and I would suggest you, if you are getting less sleep or you are having stress, it also triggers the fits.
Okay.
Are you with me so far?
Yeah, okay, okay. Yes, thanks.
And I don't want to scare you, Sylvia, but there are chances that some of the women may die, suddenly die during pregnancy.
Oh.
That's why we would like to see you, and we would like to be making sure that you are aware of it.
Oh, what do I do about that?
Yeah, that's why we will always give us 24-hour contact number. In case if you have anything which you are finding unusual during your day-to-day activities, immediately we had to report to our number. You had to contact us, so that we are here to help you.
Oh, okay.
Okay.
Oh, that's scary.
And it's not scary. We are here as a health professional to help you, so that we can tackle the complications and also minimize it.
Okay.
Okay.
Yeah.
And Sylvia, for the baby, the medication what you're taking, carbamazepine, is as we have seen, it's quite safe. But we would like to emphasize that the baby will not get any brain or the backbone defects. That's why we have started with folic acid 5 milligrams. If you had to take till throughout your pregnancy, and baby may
medication
have.
Can harm my baby?
Till now, the carbamazepine has not harmed, but it may cause baby may grow small. That's why we would like to see you frequently to do scan from 24 weeks onwards.
Oh.
And I could see that you are 10 weeks. So I would like to give appointment for the next visit, that is a combined screening test for Down syndrome. And we will do a 20 weeks detailed scan so that we can look into the baby. Okay. And around 28 weeks, we will be discussing about the birth plan. As I can see that you want to have a home birth, we will be discussing about further at around 28 weeks. Now, I would like to know, Sylvia, why you are preferring for the home birth? Any reason for that?
To keep things natural, doctor.
Okay. So in the case of epilepsy, definitely your wish will be done. But here I would like to emphasize that women having epilepsy may get fits during labor. That's a more chances. So we would like to offer you a home birth obstetric-led care unit, so that we are, as a professionals, will tackle if there is any sudden epilepsy, the seizure attacks comes. It will be very difficult to tackle at home. Are you with me so far?
Oh, okay. You mean you can't allow me home birth?
Unfortunately, it may be risky for your health as well as your baby's health. I would offer you to deliver at a hospital where all professionals are available.
Okay. What else would you want me to do, or any other advice at all?
Yeah. So I would allow you to go for the consultant-led care, unit care. Some of the cares can be at the midwife, that is called a shared care. So whenever we have any issues with your health or your baby's health, definitely we would like to see you. And after the delivery as well, there are chances that the seizures may come back. So you need a lot of support from your family side as well as from our side as well. There are some support groups you can be part of it. You can discuss regarding the condition, and you can see that many women who are having the epilepsy are doing well in their life along with the pregnancy. So you can be a part of it.
Okay.
And I would like to discuss after the delivery the contraceptive method, so that we can avoid these unplanned pregnancies in the future.
Okay. Yeah. Thank you.
With me so far?
Yeah. Yeah. I think that
Yeah,
will help.
I know I have given you a lot of information. I would like to provide you a written information leaflet. You can go through that. If you have any doubt, we are here to help you.
Good.
Okay.
Yeah.
Thank you, Sylvia.
Very welcome. Where is that? Okay. Let's stop this timer. Okay. So how do you think it went, Sunanda? Then I'll ask Shilpa, how did she think hers went? So Sunanda, how did it go?
I don't know. I don't know.
Okay.
Yeah, I will. Maybe I am not so structured and organized. So I had to practice a lot.
Don't worry about it. Don't worry about it. Yeah, structured and organized. There are much more important things than structured. Sometimes we remember things right in the end and we still score marks for asking them. Okay. So it's not always about structure and organize. It's preferred that you make a structure, but you have to, we are all humans, and even in our usual clinics, we sometimes have to go back, like, if we forget something. Oh, okay, can I also ask this? So that's absolutely fine and acceptable. Okay. Okay. So what I will do is, we'll start with what Usha did. I'll only mention few points. Usha, you do, sweetheart, need a lot more structure. If I just said to Sunanda that structure is not that important, but slightly improved structure would be required in your case. Okay. Now I have to say one thing, that we talked about fumbling. So it's not the issue. Fumbling is not the problem that ever bothers me. But there were things that I felt that you could have just avoided, and you probably, it was not the very best of the applied knowledge that you were giving. For instance, you said, you are on carbamazepine and your fits are not controlled, so you will be on 2 medicines, and that is harmful for the baby. Okay.
Yeah, I thought epilepsy is not controlled, so the doctor may add another medicine. Yeah. And I forgot, is she compliance with medicine or not? Yeah, that important point.
Absolutely. So these sort of things. So whenever you are saying these kind of things to the patient, she would start thinking in various directions, and I'll tell you what. So there are so many options, like the doctor can check, you can check compliance, and then the doctor, as Shilpa said, that the dose may need to be increased. Okay. So that still becomes monotherapy. And still you can do it. Okay. So you are saying that it will be dangerous for your baby as well.
Because I know later on I realized, oh, I should not say that.
If you are telling me that a medication will be harmful for my baby, I won't tell you, and I'll stop my medication. Okay?
Yeah, that's the biggest mistake. I realized later on. Oh.
So you have really startled the role player and the examiner on patient safety here. Okay. So that makes it very, so it makes a problem with the communication with patient. It makes a problem with patient safety. You have, kind of created risks for yourself. Okay.
Yeah.
Again, I won't ask reservation, but it was early pregnancy you asked, that was fine.
Mhm.
But that also meant that you went on and on the history. I don't remember how long did you take for the history. If somebody else remembers, it would be good, but I don't remember how long did you take. But what did you say?
Yeah, and where was the scan? I thought there is no scan and we need to do.
No, in your case, I didn't. Yeah, in your case, I didn't say that. I changed it for the other ones. Yeah.
Okay, okay, okay. So
Yeah,
that's why I thought we need
you were
to
right.
scan first. Okay.
You were right. You were right.
Okay.
You were, as per the situation, you were right. Okay.
Okay.
Another thing that was there, that yes, you did talk about the consultant-led care, but I encourage all of you that when you start talking about her management in pregnancy, you use this as your opening word, because you don't want to lose marks at all. This is communication with colleagues as well. Okay, you are saying consultant-led care, you're saying multidisciplinary, and you are saying joint clinics. Use those kind of, these are very kind of solid buzzwords which you will be saying, and they will be heard, and you will score some quickly. Okay. So yeah, that's it. You have, I have to admit, you have a language problem in explaining. You are not able to
explain in a better way.
Yeah. You're not able to explain in a way that can be a barrier. Okay. I only have to be honest here, and I know that all the lovely girls here, they all know that we are all struggling to achieve a target. For all of us have weaknesses. Okay, so don't feel any bad about that. Okay, just say to yourself that you need to focus on your language as well. How do you do that? I don't know, maybe read any small grammar books, whatever, and just spend time.
I have a problem explaining things. That I should have.
You need to probably watch more of the English soaps and dramas, and or whatever. So but
I don't know, when I speak to someone, then I don't feel problem, but when like explaining things, this is
absolutely,
I
understand. We are doctors, so most of us are fine when communicating with other people, but when it's the clinical scenario,
I find difficult.
It's because in your clinical scenario you don't talk in English to the patient, so it's unusual for you to now start talking in English to the patient. Your patients don't talk English, talk in English with you, isn't it? So that's unnatural for you. That's the reason. But you need to try to overcome that, because I would never mind anything. I'm not fond of the word fumbling at all. So for me, that won't be a problem at all. But if you are failing to explain things to me, and if what you're trying to say is not making sense, then there's a problem.
Then the problem. Okay.
Okay, so that's an issue. That's a weakness. You need to address that. Okay.
Okay. Thank you.
You're very welcome. So now we quickly jump to So I won't be going on and on about other kind of what happened and what didn't happen, because of course we know it was you did try, but you were not able to explain. You did take a bit longer in. You kept focusing more on that medication aspect, and it went a bit haywire there. Okay, so now we come to Shilpa.
She did absolutely amazing.
Amazing and excellent.
I was enjoying. I was really enjoying the way she was explaining and dealing.
Shilpa, where do you work, Shilpa?
I am in Mumbai, and I am a consultant already. I'm working at Cloud9 as a consultant, and I have my own practice.
Excellent. And despite that you're not working in UK, your communication is at par. Okay, absolutely.
So I have a lot of international patients, ma'am. So I just talk with a lot of people.
So see, that shows, that shines in us. The things that we do, they shine in us, and that's absolutely, you should not have any problems with you. One thing that I want to correct, or a couple of things, are that unless the letter says something, indicates something about continuation of the pregnancy, please don't ask the patient whether you want to continue the pregnancy. Okay, especially a patient who's smiling that, oh, I got So if I was to request that I can't continue this pregnancy, it should come from me. All of you, Sunanda also asked, I think. Did you ask, Sunanda? You didn't ask.
No, I asked.
Usha asked, yeah. Usha asked. Yeah. So please, Sunanda didn't ask.
Okay.
Yeah. So yes, this question should not be really, because if it's coming from me, that's fine. Then you address it, even if it's a medical complication.
Okay.
Yes, if it's something like severe pulmonary hypertension, where you are worried that there's a high maternal mortality, that's a different issue. This is nothing near to that. So please don't say that. Okay. Are you happy to continue the pregnancy? If I'm not happy, I won't have that big cheesy smile on my face, and I won't be, and I would request myself that, oh my God, this unplanned pregnancy, please help me sort this out. I'll die.
Okay. Oh, yes.
So don't say that. Also, you don't need my permission to look at my notes, please. All of the world keeps saying that, and that's not correct.
Okay.
You don't need my permission to look at my notes. You only need my permission if I was being looked after at another hospital, okay? And now my care has been transferred to you, then you can ask that if it's okay, then we'll write to your previous doctor to share your notes with us. Would that be okay? So then my consent is important. If my care is, under your hospital and you're accessing notes, then absolutely you don't need my permission. That is a hospital. Notes are hospital property. They're not patient's property, okay?
Okay.
Yeah. So I can look into all your notes if you are my patient. I can look into all your notes when I'm, looking after you, when I need to manage, you are under my care. I don't need your permission. And if your care was transferred to me because you were in a previous hospital, then you moved your home or something like that, and now you've come under our care, then I'll say that I'll get in touch with your hospital to get your notes from them. Would that be okay? Okay, so just ask like that, and that is another thing. Okay, so because Shilpa, to be honest, you are already at a level where I have no doubts. If you today sit the exam, you will probably score 75%. And I think with the improvements, you can go up to 85 or even more than that. My score was 85. So I will say, yeah, you can easily go to that mark, easily. Okay, you just need to make sure whatever you're preparing, because you probably could get this from any UK based person, this kind of tweaking of your station practice. Okay, that will be required for whatever stations you're doing, just to see that you're not going. And your communication, yes, excellent. What else did I write for you? You addressed contraception. That was, and in a beautiful manner. You reminded me how I talked about contraception to my spina bifida patient in the exam. And she had these big smiles as well. She said, yeah, I know, thank you. Yeah, so, and emergency contraception patient as well. So yeah, your contraception, I loved it, the way you handled. And you said the word stress, yeah? None of you mentioned mental health support to the patient. Why was that? Didn't you think?
Yeah.
So this is, as I said, you still, as I'm already saying that, Shilpa, you're already at a level of scoring like kind of 75%. You're not sitting on the fence. Some people score like on the fence, which means that they could either pass or fail. If they fail just by tiny percent, which they keep feeling bad about later, that why did I fail by 1% or things like that. So I call them as fence sitters, like passing or failing on the fence. That's a very tragic kind of fence line, is very tragic. Okay, but you are much above that. So I'm confident about you. You sleep now until your date of exam and you will pass by at least.
I hope so.
Yeah, no, this is my feeling on this one at least, okay, that you are right there, okay, but that doesn't mean that you shouldn't, because we always keep a margin of error, isn't it? So if you're focusing, just make sure that you get to learn the things. As I say do in Rome as Romans do, and do in UK as UK people do.
UK people,
There's a
yeah.
UK exam.
Yeah.
We just see that. Okay. One thing that you said, I am going to book you with a consultant. I am going to book you. We don't dictate anything to our patients. These words kind of, pinch us. When somebody says like that, I go like, I am going to, what do you mean? So it's not like, it's just slight improvement. Okay. I'm not saying they will be negatively marking you, because it's just one thing. But if you say 2 or 3 such things, your 2 could become 1. Still, that will give you a 75% score at least. This is my humble opinion. Okay, that you are at least still with that, you are still at 75% score. But if there is something available for free, then why don't take it? Okay, so for that, I'll say that try to mold your sentences always that we'll offer you consultant-led care. So it's always offer. We are used to talking to our patients as partners in care, not as I will book you. Who are you? It's like, no, we'll offer you a consultant-led care. And yes, I think you said epidural, but then you said that it will be explained to you, which is fine. Yeah. Okay. So I personally feel that our patients are not that bad with the jargon. They are very accepting of the jargon, but the role players are not. They're fake patients. They will say, what's epidural? So there you can say, you can have an injection in your back, but you kind of covered it up with saying that, that will be explained to you. I like that. You kind of gave a blanket, of safety to yourself there. Okay. That was good. That's it really. I don't have any issues with your station. These 2-3 things, if you can, we say that whenever you find an opportunity, try to have this in your mind about, antenatal care, intrapartum care, postnatal. So postnatal, I always say review of medication, like assessment and review of medication, A, B, C. So B is breastfeeding, C is contraception, and then review of medication and to be seen by the consultant. So think on those lines. So absolutely fine. Now coming to Sunanda. Sunanda, you said, you used a word, Sunanda. Okay. You asked about cervical screening. She was early pregnancy. It was good. You asked about that. You asked about history of surgeries and allergies. That was fine. I would like to, you said as well, I would like to, okay. So you got the message now that it's not us who like to do anything. I would like to offer you is fine, but I would like to do this is not fine, okay. I like to offer you. So, or we recommend this, okay. We can recommend and we can offer, but other than that, we don't just say that I will like to do this, okay. So another thing you said was my senior consultant. So there's nothing like a senior consultant. So don't say senior consultant. If you have something in mind regarding that, you can say, you will, in your mind, you should be thinking that there will be a consultant who has got special interest in medical disorders in pregnancy. They will be looking after, but you're not going to waste your seconds saying this to the patient. You just say you'll have a consultant-led care, we'll offer you a consultant-led care, and that's it really. So senior is a bit of a foreign word here. They won't deduct your marks on that, that's for sure, okay. But yeah, if you can do better, then why not, okay. So then you talked about her fits and admission, and I didn't hear you saying that your epilepsy doctor will need to change your dose.
Yeah, I didn't say that.
Yeah. Because she's saying that she has fits, that will be safer to say that. I think that only happens when we get a bit of stressed that, about other things. That can happen. We can all do that, okay? So just try to relax, because we all know that but you just didn't mention, yeah? So just try to relax. And then you said about Yes, you said there's a risk of death, and I saw Shilpa was smiling as well, but there is a risk of death. There is a risk of death. You said absolutely right thing. Shilpa probably didn't find time to mention that.
Should we say or should we not say? Like, because as a role player, I felt role player was not happy to hear that.
No, I was acting natural, isn't it? That if a role player hears that there's a risk of death, they will naturally respond, yeah, really? Oh, so if I didn't do that, then I'm very unnatural, isn't it, as a patient? But you were right. What I do is normally if there is something, I always try to associate it with the medication then. I say, I want you to be really compliant with your medication, whilst you can do a bit of be a bit irregular before pregnancy. Pregnancy is a condition where women can have a higher risk of sudden death, which we call as SUDEP, is sudden unexplained death and all that. So you are saying that she's thinking that, okay, so it's a phenomena that happens, so she's not taking it on herself. She's relating that now I will have to be more compliant with my medication. Okay, so always try to link it so that she knows that there's a solution, isn't it? Avoid stress, be compliant with your medication. That's the thing that you will say. Okay, so I said that's scary. You said it's not scary. Don't say that to the patient.
I really didn't know what to tell.
No, you say, I understand.
Naturally,
you have to pause. You have to pause and think. Don't just reflexly say things, please. Don't just reaction. Don't say it in a reaction, because in a reaction we just say whatever is on the tip of our tongue. Just give it slight pause and just you are pausing. You are appearing like you are empathizing. That's why you are pausing. You are actually pausing because you are thinking.
Yeah.
Okay.
I really didn't know because.
This is a tactic, yeah. I'm pausing. I'm doing all the Bollywood acting as if I'm so empathetic that I'm pausing, but in my mind I'm just trying to think of the best words. I understand, but we are here to look after you. Yeah. So you don't say it's not scary. Just pause and make your eyes like you're caring. Okay. Yeah. In the meantime, that gives you a pause, gives you time to work in your head. Okay, time to synthesize your words. Okay, so yeah, don't say it's not scary. And then I said, you started telling me about the drugs. How will they affect the baby? And I said, oh, the drug can harm my baby. Now, this was your chance of patient safety that you missed. I gave you a clue there. In my heart, I'm thinking, I am going to stop my medication. That's okay. I can have fits, but my baby shouldn't have any problem. Okay. And you didn't catch my cue there. I said, oh, it can harm my baby. Next thing that you should say is that, I understand that your epilepsy uncontrolled epilepsy harms your baby much more than a medication can harm your baby. Okay. So please don't stop your medicine. This is your very important patient safety point. Okay.
Yeah.
So all of the people, they should say to the patient, whether she expresses this or not, that please do not stop your medication. This should be very clear to the patients who have medical conditions. Please do not stop your medication. That's a good sentence. If you say that, that scores you much better in patient safety. Okay. So and here I gave you a cue. After the cue, it was like, it shouldn't be missed at all. Okay? You have no excuse to miss it then when I say that it will harm my baby. And you said we'll allow you to go for consultant-led care. I think it was a slip of tongue. I felt it was just a slip of tongue, so be careful. You offered me support groups, and you somehow, I don't know, you said something like your wish will be done when I said your about a home birth. So that thing as well, just say, you can say that we will have a detailed discussion about it. This was actually the time when you will have a detailed discussion about it. So you could have said that, whatever you wanted to say right there. So I don't know why you said, I again thought that was probably your mind was processing something and you just said it before full processing. Okay. So That's it really. Now, both of you, Shilpa, your history went beyond 5 minutes. Okay. So yeah, but your communication was so excellent that you still ended up scoring very good in that. Okay. So what I say is that try to keep an eye on the timer. Did you guys have an eye on the timer when you were talking to me?
Yes.
And you, Shilpa?
I did not. I did not. Was not
Yeah,
seeing that.
I felt that you didn't have a, yeah, because your history went far beyond 5 minutes. Like it was like 5:34. I noted that you were on the history, and then you switched it sometime. Okay, so it's done very well. I think you get the points that I'm trying to say here. If the patient doesn't ask you much questions, if the patient feels like, seems like a bit passive, that leaves it to you rather than guiding, most of the patients will guide you what they want to know. Okay, most of the patients, when you start the conversation, you will ask them, are there any particular concerns and expectations you want me to address? Once you said that, whatever her agenda is, she will have to reveal to you. You don't leave it to guessing. You don't leave it to, okay, I'll fire all my arrows and see one or two of them will, end up on the bullseye. Rather than saying, just ask her in the beginning. I always ask in the beginning, so as you asked that, I see that you've been referred for this and you have this. Yes, is that right? Yeah, okay. Are there any, this would be my next question. Are there any particular concerns or expectations you want me to address, or you want me to generally talk about pregnancy in epilepsy? And there you go. She will tell you her, where are the marks? She'll tell you where are the marks sitting. Okay. And then you will address that. So this is your kind of, hunting technique. You are hunting your marks. This is your hunting technique. Otherwise, you will have to throw lots of arrows. Some of them may be missing the target because you don't know where the target is and what the target is. Okay. So this is my a little bit of tiny tip to you. I say medical conditions in, let me share something with you. So I asked my students to, kind of think of a medical condition when you're revising medical condition in pregnancy. Revise something like this. Let me make it bigger. Okay, so this is your medical condition. Gone too big. Wait. Okay, so whenever you're revising a medical condition, I say that here you write down your medical condition. Are you able to see the mouse?
Yes, yes.
Okay.
Marks, no, but we can see the questions. What is it? You may or may not need to tell the patient. We can read that.
So what I'm saying is that whenever you're revising any medical condition, whether it's Marfan's or epilepsy or sickle cell or thalassemia or whatever on earth, you ask yourself, is this an inherited condition? This is what should be quick. As soon as you see this question in the exam, these are the boxes that should come into your mind as well. Is this inheritance? If it is, then you will have to, of course, you may end up talking about it to the patient, and you may need to think about partner screening. Okay, the inheritance pattern, partner screening and all that. And you don't want to miss those things. Then are there any criteria in this condition that are, important for pregnancy? Like, for instance, if it's Marfan's, we're talking about the aortic root dilatation. If it's phenylketonuria, we're thinking about phenylalanine levels. Okay. If it's a renal condition.
Phenylketonuria station, recall station?
I have seen it somewhere in the past.
Okay.
Very old ones. I've seen when I started teaching, actually, then I haven't tried to dig. So then I went back and I saw, there was a mention of phenylketonuria. As a medical, so it's a good idea to give it a bit of a revision as well. Okay. So what I'm saying is, whenever you see a medical condition, ask yourself like this: is this an inherited condition? What is this condition? How does it affect the pregnancy? Are there any criteria or levels that are important? And do I know them? Okay. So remember all those criteria for various conditions. Like if it's renal, then what are the levels accepted for, to be pregnant, EGFR and creatinine and all that. And if it's Marfan's, what's the aortic root dilatation, and things like that. Okay, so then you will think in your mind that, of course, that what systems are most affected in this condition. Some conditions will affect heart, some will affect kidneys. So as soon as a medical condition comes in the exam, your first 2 minutes, the processing time, you are processing this in your head. Okay, this is your template or your framework or your thought process in the first 2 minutes. Okay, and why I've left it blank? Because the miniature things don't matter as long as you remember the big aspects. I tell you, you would have, all of you would have taught students, and you know that if you start writing all the things in your slides of PowerPoint, then you are, you know, not that fluent in your presentation when you are presenting to a, you know, a classroom or your colleagues or whoever. But if you have only written headlines, then you quickly go about this. Yeah, this one, this one, this one, this one, this. So the way to be fluent is minimize the text when you are trying to, you know, don't clutter your head with lots of text, just headers, inheritance criteria, what's the condition, what systems are affected, then don't go into nitty gritty and don't go. This is just my tip for how you should be revising all the medical conditions. I'll share this page in the group so you can, you know, you can kind of try to make yourself this kind of. So how will you then, what next will be, how is the pregnancy affected, and how will I manage this pregnancy? Okay. And for instance, I've written here, are there any coexisting issues? For instance, high blood pressure, mental health conditions, obesity, is a patient on warfarin for some reason? So then you will come think that, what am I going to do in regards to delivering this patient? Are there any different things that will be done? Like thalassemia patient, I'll need to give desferrioxamine, yeah. In sickle, I don't need to give in the labor. We are talking about delivery and labor. So in the first 2 minutes, this is what I'm saying to you, that in the first 2 minutes, that's your processing time. Those 2 minutes, don't try to remember or ratify that question that's written there, okay? Because I told all of you that you can open the question in front of you throughout the station. You don't have to remember that this was the name of the patient, this was the age of the patient, this was the BMI, this was on the scan, these were the, no, because I told you that you can open the station, they will never know that you're looking at the station and not the patient. We'll do that cheating there, okay? We'll cheat them. We'll keep smiling at the station, looking at the station, we'll keep smiling and saying, they're thinking that we're smiling at the patient. Patient is squeezed down, we're still able to see the patient, but actually we are looking at our station and we say, okay. So because everything is now in front of us. So the first 2 minutes, please don't waste in trying to memorize the information that's given in the station. Okay, first 2 minutes is your processing time, that what are the various things that I need here. Okay, what are the various aspects, or I call bubbles. Yeah. So let's discuss matters that matter in my opinion. Okay, I keep listening to this word fumbling. Okay, do you all guys get this feedback from people? Oh, you were fumbling, you were fumbling, you were fumbling, you were fumbling, and this terrifies you in a way?
Doesn't get a feedback actually, but I feel myself that I was fumbling, so that feels bad.
Okay, anyone else is worried about fumbling?
Yeah, me too, actually.
Okay, who else? Anyone else who fumbles or who fumbles and they are worried about it? Yeah, so at least Usha and is it Umme who said, Adila who said, yeah, okay. So Sunanda, are you ever worried about fumbling?
No,
No,
Sunanda is very good.
No, till now, no one said, I don't know.
Yeah, no, I heard Sunanda say.
What do you think?
Cases,
what do you think is
very
fumbling?
good, fluent.
Okay, that's good. That's good. But what do you think is fumbling and how is it harmful?
It's not harmful. It's a natural phenomena. When you speak, you cannot continuously non-stop. You can't talk unless your speech is already prepared. You know, it's not possible.
Yeah, so
yeah, it's not. Yeah.
Usha, why do you think you got this feedback and it makes you worried then if Sunanda is saying this thing?
Because I think, like a role player or examiner will think, my communication is not good or my fluency is not good. It's like inside feeling.
But they
And
know that
also,
you are not from UK, yeah?
yeah, I'm not for UK. That's the other thing. But I'm living in UK, so
Are you living in UK?
yeah. So that's the thing,
You've never worked in UK?
No, not yet.
Okay.
So
Okay, but yeah, they are taking you. Are you appearing as a global? Yeah, global.
yeah,
candidate.
yeah.
So they will think that you are not from UK, and they'll give you that room. Okay, to be a bit different. That's fine, absolutely fine. Even if somebody is from UK, I want you to please remember that it's absolutely, as you said, Sunanda, that this is absolutely natural. It's not a prepared speech. We don't go in with prepared speech. I think, and I know people don't like when I say things like that, but I think it's just when a person who is giving feedback don't have lots of strong points to give you feedback on, then they start focusing on these kind of things. Okay, you were fumbling and you were this, or maybe they just want to populate the list of their feedback. So they just add something on it, unfortunately. Okay, I don't want any of you to worry even for a minute about this. Okay, take your time, take your pauses, think about whatever you are, doing or saying or talking or, thinking in a pause. Take your time. It's absolutely fine. You have to be a safe doctor. You have to be thoughtful as well. And it's natural. No worries at all. Okay. Yeah, if you are totally lost in the station, that's a different thing. But again, that fumbling will not be the reason for you to be, that would be giving a wrong impression to the role player. It will be if you really are lost, if you really don't know what to do about anything. And we can, yeah, there are solutions to that as well. Everything can't be covered in these kind of sessions, but there is solution for everything. Okay. So fumbling, no, I don't think it's harmful. Okay. And I don't think that you should waste your energies on fumbling, because this is not an audition. Yeah. This is an exam. You're not going in for a Hollywood or a Bollywood movie or a British soap, performance or something like that. You are there for you are a patient doctor in a patient doctor interaction, and that has to be natural. Okay, so don't worry about that, please. Again, another thing is softness in the tone. I see people so impressed by softness in the tone. I think half of the candidates would be probably feeling a bit low that, that person is so soft in the tone and I'm not. Okay, yeah. Especially when when those people are telling some of the people are giving feedback that, oh, I was so impressed by the softness of your tone. So you're thinking that, oh my God, I am not soft in my tone. Where do I go? So I would again say, this is not an audition. Please don't waste your time in these kind of worries. Okay, does it assure you in any way that this probably is helpful, because now you can direct your energies to what needs to be addressed? Yeah, here goes. What do you think?
Yes.
Yeah, so softness is good. You don't have to be sounding harsh. Okay, you don't have to be sounding. Some people's natural tone is very, very high and very, very kind of, they sound aggressive. You should not be just that. Otherwise, a normal tone is absolutely fine. The way, if you are talking like, okay, that you maybe normal for you, but it's not normal for the patient. They will be terrified that you are angry. Okay, that you're probably doing a kind of, some people who absolutely have, there are very few. I think I've heard one or two only, okay, ever, who talk in that way. Okay, yeah, I told you. Okay, so that is not acceptable. Other than that, please don't neither you get too excited that your tone is soft, because that's not the only thing that you will be assessed on, and that's just a kind of a, that side dish kind of thing. Okay, it's like a side kind of attribute. It's not going to make lots of difference. Just make sure that your tone is not too harsh, not too aggressive. Okay, next thing that I would like to ask you is practice. How many of you think that you need to practice stations in 10 minutes? All of you? Come on, girls. You can turn your mics on. Don't need to be mute. Please turn your mics on. Please interact. How many of
I
you?
agree.
Yeah, I agree as well. Yeah. All of you think that practice is very important and it has to be in 10 minutes. Yeah. Yeah. Okay. Anyone disagreeing with that?
Yeah, it is important, but like taking history, it takes time, and then we think, how could we finish in 3 and 4 minutes, because we have to ask so many things, and then for management, time is less.
So Usha, do you think practice is important?
Yeah, it is important, definitely.
Yeah.
Yeah,
You have to finish the station in 10 minutes. Practice is important, that you keep on doing lots of practice, that you finish the station in 10 minutes.
No, actually, it is not important to finish everything, but at least the most important things should be done.
Who is
I
that?
think this is Palak here, Dr. Sam. It is not possible to finish everything, but at least the important ones we should be doing in 10 minutes.
Now you girls will remind me again to talk about this. Okay, I won't talk about this at this point. Okay, just remind me towards the end. Okay, and we'll talk about practice and whether it's important and how much is it important. Signposting, I already indicated to lots of you. I think lots of you already understand that what we do here in UK is not what you were being preached. Okay, we don't signpost for so many things that you keep signposting. It actually makes the things very awkward. Okay, so there are normal things. If you're asking normal things in a normal way, that's how we go about it. But if you try to signpost, the patient can suddenly start feeling embarrassed that, okay, this was something embarrassing, I didn't even know that. So that could suddenly become, something strange for them. So you're saying, I'm sorry, I'm going to ask you some private questions. And she suddenly is going like, okay, is this private? Okay, is there something to hide? Like I smoke, or I drink alcohol, or I don't drink alcohol and all that. So we don't signpost for smoking. We don't signpost for alcohol. We don't signpost for taking sexual history. Okay. You have to remember, this might be difficult for you to digest, but we don't signpost for his sexual history, please. You can call us that we are kind of, too much, whatever, too liberal, or I think it's the patient-doctor interaction here is much more respectful, in a way that whatever we ask, our patients take it like very lightly and very, they know that everything we are asking is for their benefit. We've never faced a situation when I asked a patient such a thing and she started feeling embarrassed or awkward, or, but if you start highlighting, if you put the heading there that this is something embarrassing that I'm going to ask, then she will feel that, oh, suddenly, okay, all right. So why is the doctor feeling this way? That kind of creates a gap between you and the patient. So we don't do that. And it's not only us that we don't do in our practice. Even in the RCOG course that I attended, very bright, brilliant, well-known consultant, Sean Hughes, he actually raised that point there. And I loved it because he raised that point here. He said, we don't know why people keep signposting for these things. Our patients talk everything to our doctors, and they don't feel any hesitation that they're. I would only, signpost if some, I was asking about multiple sexual partners, and I'll slightly give a slight kind of, that if, depending on our age as well. If she's a young girl, I will see that she may be hesitating in sharing me, so I can signpost slightly. So multiple sexual partners, I can choose. Sometimes even in that, I won't signpost, okay? But I could signpost for multiple sexual partners. I could signpost for history of STIs in which patients, not in all the patients, no. In, say, somebody is over 40 or 45, you know, like she's not in that age range when there is a high risk of chlamydia, like young girls and all that. If I'm saying that, I'll probably give a little smile and I'll say, my apologies, ever treated for any? So if I feel in that particular situation, and I won't do it for all patients, okay? If I'm asking the past history, even in a 45, I'd be fine. I hesitate in asking so bluntly in women who are like postmenopausal, because if it's not relevant and if you have to ask for some reason, then yeah, I'll slightly signpost, you know, and then you can ask. So it's only that kind of, where else you would probably signpost. If you are asking about how the partner is with her, you can slightly, you know, especially when you are not in the routine questions, but when you are asking, when you are suspecting that there could be domestic violence that is hidden, okay, then signposting is a good thing, because suppose she loves her partner and he loves her and you are talking bluntly, she may think that, you know, what kind of, you know, why you, she may feel a bit in, you know, that you were a little bit intrusive there. But you say that, you know, I really apologize. This is just for your own, you know, safety that I'm asking these questions. Just, you know, do you feel really safe at home? Is everything okay with your partner? So that's a different thing, you know, that could be considered intruding questions in some patients, okay, when everything is seemingly perfect and all that. Otherwise, I always say, please remember that we are gynecologists. You remember where our hands go in the examination, and if that is not intrusive, then nothing else is intrusive, okay? So please remember that, okay, nothing is intrusive.
How do you say about in the professional, when you ask about occupation, what do you do for your living? She says sexual health worker.
Yeah, so what do you want to ask next? Just say okay. Okay.
That's all.
Yeah, so why do you want to say that? Oh no, what, why are you
no I just thought like what she's using any condom for her protection, her own protection.
You'll ask those questions, absolutely, but be normal. She's saying sexual health worker, you say, okay, so are you aware of all the safety practices regarding, yeah, all the safety practices regarding, so anytime you have, you know, unprotected sexual intercourse, have you ever had that? And if you have that accidentally, or sometimes when the condom ends up, you know, in a, you know, split condom or something, so do you know that then you immediately should get in touch with the sexual and reproductive health services so that they can screen you for some infection. So be normal. You are not trying to become, so if doctor becomes like, oh, she's sexual health worker, oh, you know, say like she's in a sexual,
because here also one famous sentence is there that they say, no, I'm not being judgmental about your profession, but I would like to, that sentences are like framed one, you know.
You know, when you say I'm not being judgmental, that actually is I am being judgmental. That actually translate in real practices that actually this is I am being judgmental, or it would sound like, you know, you are such a, oh my God, this is what you are, okay, I'm doing a huge favor to you that I'm not being judgmental, otherwise this is something to be judgmental about. So it actually translates as that is actually quite pushing away, you know, creating a gap between you and the patient. I'm not being judgmental.
Because imagine 14 students coming and telling the same sentence for the same station, then there will be
there will be one candidate who would remember my line, and he won't say that, and he will pass. Okay, pass the communication domain, I mean, okay. because that's quite a rude way of saying. I mean, even in UK, I've seen somebody saying no judgment, saying like that, no judgment, and then continuing. But I've seen somebody local here, local person, local doctor saying like that in one of the stations, and it kind of was like this. Rest of the people were like this, no judgment. That actually means judgment, you know. So yeah, we won't say that. That's not a good sentence to say, that I'm not being judgmental. Okay, that says a lot actually what you are thinking, you know. So no, we don't say that. Why would you say that? Do you think that it feels comfortable, somebody coming to you and saying, I'm not being judgmental? No, that's not a comfortable sentence at all. Try to apply it on yourself. If you feel uncomfortable, then the role player will feel uncomfortable too. Okay. These are the sentences that make me laugh. Okay. And but remember, there are hundreds of these things. When I was teaching my students, there were hundreds of these things that keep coming. So I may be able to correct 5 or 6 or 10 here, but it's a process that you know, it's a very rigorous process. There are lots of things. For February exam, when I was taking a circuit, one of the students found out, only in the circuit, she found out like 10 or 12 such things. And she was like, Sam, these are the things that came up in the station and you've told me. What happens there? I may be having hundreds of them. So unfortunately, that's the case. I don't have a solution for you for that. I only think that please try to get only feedback from people who are from UK. You get feedbacks from people who speak very softly. And when I listen to their feedback, it really is like, really? This is the feedback. Okay, so please choose wisely. There are other people as well. It's not only me. There are, I think at least one group is there who is, the girls are from UK. Okay, so please be wise with your time and your money. This is your family life that's being affected. Okay, because this exam, it kind of is very distracting, distorting the family lives. Don't take your time that easy. Okay, so please choose wisely. Please go with something that you deserve. Okay, and you deserve the best. I believe that. Okay, so now my next question from you is history. As Usha pointed out, that history is not all the times possible, and you don't end up finding time for the management discussion of the management in 10 minutes if you take a long history. So that is something that you have to work upon. History is not, it should not be the way you take history, most of you. Okay, you take very long histories. You are very much stuck with detailed history. You are very much stuck with those old templates that people have created who've never worked in UK. And they have made long templates and you feel stuck with them, I believe. Okay, so in RCOG course even, what's his name? He's a very senior guy, Dr. Iskandar. So he actually pointed out, he highlighted so many times. He said, please, he almost begged that please don't take detailed histories. Please take targeted history. Okay. Anyone has a question on targeted history? Mustafa or Palak or Shelpa is here, so I didn't see your name, Shelpa. So anyone has any question about targeted history versus complete history?
I think this is the problem because we don't know what should ask. So we keep asking all the templates.
I can give you a tip, okay? I can give you a tip, but it's a matter of, if there is any practice that's required, is a matter of practice along those lines only, not the practice of 10 minutes and cramming everything in 10 minutes. That's not the practice that you guys require, okay? Practicing what is required in the station to reach a reasonably good diagnosis or a list of differential diagnosis and to plan for the management, okay? So what you do, open any big recall, file like old stations, whatever, open it in front of you, have a rough notebook in front of you, like any, say, or make, have
Okay.
dedicated notebook. Go question number 1. You are addressing question number 1. You are thinking in your head, what history would I need in her circumstances? What's more important? And, you know, make a bubble there. I taught my batch, my February students to go with the bubbles. Okay. So I always say, make bubbles like history. I need this. So 3 or 4 points there. Move on to the management. This. What else will I need in this station? What can the role player ask me? She can ask me, what are the effects on my baby and me? Okay, so there's a bubble there which says effects on the risk to the baby or the mother. She can ask me, how will you take care of me in my during the antenatal period? So you can say antenatal care, you know, and you can write the multidisciplinary team, consultant-led care, and all those points. Does she need extra scans, extra bloods, or whatever? And who are her multidisciplinary team? Is it cardiologist or neurologist or whoever? So whatever is involved. So then you make another bubble. Is there anything during the labor and delivery that I'll need? And another bubble for postpartum care. So you should know everything. She may not ask you all the things. Okay. So then you tell her what she asks you. Okay. So that means that if I go back to my question about whether you needed practice or not, you actually don't need to practice everything in 10 minutes, okay? All you guys need is to make those bubbles for all the possible stations. You decide in this time, in these weeks, you address those stations and decide, okay, if this is the station, these are the history points that I'm not going to miss. These are the aspects that I'm going to remember. And I'll keep asking her, what would you like me to talk about? And, you know, then I can tell her about those matters.
Okay. Okay. Can I ask one thing? Just suppose a patient come to us asking a birth plan. So patient already 34, nearly 34 or 32, whatever. I mean, 34. And she is asking a birth plan. So what we need to do, we certainly not miss, like if suppose she is already 34 week, do we need to ask about smoking at that point?
So that's a very interesting and very important question. Okay. So now I would say no. Okay. No. Because you have to, this is where you know, they would probably have given you some history. If she is a patient, they would have probably given you that this is her, these are her details, okay? And she wants to discuss birth plan. So it's a no. We do say that for smoking and alcohol, we do say, because they are patient kind of safety issues, then it's, if you can find time for asking quickly, then it scores you. Sometimes they may have it on their checklist. It may score you something, but rather than only focusing on the smoking, I would say, if you keep in your mind that you're not asking really reservation to blood transfusion, you're not asking, you know, family history of cancers or like that, you know. So smoking and alcohol, what I do is I keep them like a spare kind of in my mind, that if I end up with, you know, everything addressed, I may ask. But I can give you an example. There was this which patient, diabetic lady. Yeah. No, I didn't ask her at all smoking or alcohol. Yeah,
because other things are more important than
absolutely
smoking.
Because she was already at, say, 36 weeks.
36, I mean
37. Okay,
37 or whatever. Yeah.
So I didn't ask smoking or alcohol.
I will. What I'm thinking, I will ask if I get a small baby on her scan. Then I will ask to find out.
Excellent. Excellent. This is the approach, because whatever pathology you see, then relevant to that you can explore.
Yeah.
Okay.
Not in all cases. Okay.
Yeah. For instance, this one was actually having a big baby. So our focus was on her diabetes. Okay?
Diabetic, yeah. So if it is a small baby, then we'll ask, okay, smoking or early pregnancy, bleeding, whatever cause. And one more thing, Like if patient, if she is coming here, do we need to ask about cervical smear at that point?
No,
No, no,
no, no,
no.
no.
Yes,
I
but
wouldn't.
yeah,
If she's early pregnancy, booking appointments and all that,
yeah.
then yes, okay.
Then yes,
Then
okay.
yes, but if it's a birth plan, and you can always say any other issues going on. So she can, suppose if you asked a history and you are not sure now whether she has she was asked to go for another cervical screen because there was some pathology detected, or whether she's on citalopram because she has a mental health issue. There could be so many, small little kind of issues going on around her. So you can always say, is there any other issue that you want me to address? That's it. You have covered it then. Okay. So I wouldn't want you to waste time. Targeted history, they keep saying targeted history.
Yeah. One more thing, like blood group and reservation for blood. Blood group, we know,
So we don't ask.
nobody remember their blood group.
Absolutely.
Nobody, they don't remember.
Absolutely, Usha. I keep saying to people that our patients don't know their blood.
No, they don't know actually blood group. Yes. So, but reservation for blood transfusion, suppose she is in early pregnancy or late pregnancy, that is, I think, important.
It's something, let me tell you one thing. So if there was a patient who is going imminently going to theater for whatever reason, okay, maybe she is going to be having a section, maybe you discover that she's placenta previa, maybe she's an ectopic pregnancy or whatever, if there is a possibility of in near future there's going to be, she may end up likely in theater, then the question becomes much more important. In all other scenarios in early pregnancy, it's okay to ask. And it's okay to forget or not ask if you don't have time, if you're struggling with time, then you don't worry too much about it, okay? So if it's an early pregnancy and you can quickly ask, you have any reservation to blood transfusion, fine. But suppose you are struggling with so much more going on, I'm quite pretty confident on that they will not have it on their checklist, okay? Because they will have it on their checklist if this patient is a placenta previa. Yeah, even if she got, if her 20-week scan is showing that placenta is covering the os or is near the os, and you see her at 24 weeks, then I'll still ask,
Yeah, that is important because she will have, so, and suppose like she's coming this, suppose, this is a birth plan. Do we need to ask here reservation for blood transfusion? She might end up in cesarean section.
Yeah, not necessarily, but yes, absolutely. If you are, if you are thinking that she could have any thing could lead towards cesarean section, and you can ask, if you were thinking from the birth plan that this is like more likely a low risk and she's going to be, normal delivery, and you are not finding time to ask, absolutely fine. Because the thing is, you always have to remember that whenever somebody will be talking about, say, section, consenting her, or all that, they will ask these questions from her. So it's not unsafe if you forgot at the birth plan. It's not patient safety issue, okay? If you have to remember that when is it that we say that it's a must, when we are worried that it could become a patient safety issue, okay? So you see that if it's an imminent kind of thing, then yes, okay, otherwise don't worry. So next, any other question that you have in your mind, or shall we move on to the next one?
Yeah, you can move on if any question comes up.
Yeah, sure, you're welcome to ask, okay? Next, my question is that most of you say at the end of an appointment, I'll book you an appointment with my consultant next time. Why do you do that?
Yeah, they said,
when do you need to do it?
they always say, okay, next appointment with my consultant. This is
for
continuity. For continuity, I don't know this. We have,
Booking appointment with the consultant is only when the consultant is away and he's not available. It's the station says that consultant is sick and patient wants consultant. So we have to tell that word. Otherwise, not required. You have to just inform. Consultant should be aware of the.
Absolutely. I hear a lot of people who just do a normal station and in the end, they just give me a shock by saying that I'll book your next appointment with a consultant. And I'm like, why? So sometimes we discharge the patient to the, like patient comes and we've sorted her problem out and we'll see her maybe in 6 months time. I'm not going to say to her that I'll book your appointment with my consultant in the next time. Yes, in the consultants, all the clinics are consultants clinics, but if you specifically say with my consultant, then she will go home and with this frame of mind that maybe I'm only going to see the consultant next time. Next time she'll be unhappy that you offered me consultant, now where is the consultant? Okay, so if it's only for where the patient is requesting, or you think there is a high risk of, there's some reason for the consultant to personally see her, then yes, you will say, otherwise no. There are some other stations where their negotiation failure has happened. Okay, you tried to negotiate, she is not getting convinced, then you will say consultant appointment. Can you give me an example of that?
Yeah, like she's asking, suppose a high BMI or multiple pregnancy, and she is asking home birth, and she doesn't want. She had a bad experience in her previous delivery, so in that situation, we need to say, yes. Oh, I'm sorry, I did not.
That's a good example.
Convince you.
Yeah. So wherever there is failed negotiation, you try to say something and she is not getting convinced, and you think that it's important for the discussion to be taken place by, with the senior person. So even if they have to accept her side, then it's them who will take responsibility of going with her, So that's the, where's my lab?
Also, if she is a low risk patient, she is asking, planned cesarean section. So then,
so any negotiation failure.
Your
keyword here is negotiation failure. So if any negotiation failure is happening, then yes, you will then offer her appointment with a consultant. Okay, so we are not then dragging it, like in each station. If you end up saying with the I'll book an appointment with a consultant, then I sometimes laugh that the consultant may end up firing you. And why are you sitting in my clinic if everyone has to come back to see me? Okay, so that's only a joke, but what I'm trying to say is that you are doing the consultant's clinic with them. If you bring every patient back to the consultant, then they'll think that why are you there? Why do I need to see all the patients? Okay. And now my next question is about templates. So how many of you think that you can't do anything without the templates? You need templates. Anyone? How important are templates?
Template, you can, basic template you need to know, but you can change your template according to case.
Yes. What I would also want to focus, this is the approach that you should use, but that template is something that we learned in the medical school. We don't need any new template. Okay, we don't need any new templates in there that do this, ask this, because have you ever been in a station where the role player is sitting in front of you, and you are feeling that you are thinking like that okay, what was written in my template? What's next? Have you felt that kind of thing, that you're thinking in your head now, what's next?
Not now at this, because we have
you've practiced
everything. We have practiced, so you need to know.
Absolutely. So if anybody who is new to the preparation, I would rather encourage them not to go with the lines of the template at all. Okay, always make yourself only some sections that this is what I want to address, this is what I want to address, this is what I want to address. That will create fluency. You don't have to keep thinking of the next word or step or something. And what happens is that even you guys who are very you who have done lots of practice, I can tell you that sometimes some of you sound like reading rather than talking to the patient. Okay, you may not feel it, but we as listeners feel it. Okay, And that happens because in your head, you are rehearsing the template lines, okay? Yeah. So please, templates just to an extent where they can help you, and don't make them, don't let the templates chain your minds, okay? Yeah. So that was about the general kind of things. Let's go to how I think, let me